Great case. So this is a 55-year-old with left ankle, known recurrent gout, had end of January onset of pain, swelling over the forefoot and sole, possible misstep trauma. The question is plantar fasciitis with a tear. What's going on at the base of the third metatarsal? Is this a stress reaction or post-traumatic contusion? And how to interpret these changes? Is there a possibility for gout? Thank you for presenting this case. And there are a lot of sequences included here. And of all the sequences that I see here, the one that I love the most, and I'm so glad you're using it, is the STIR, because I think even between the Dixon and the STIR is still my favorite. And we can see that the patient has some degree of metal, and that is hurting us and sort of why we are using all these problem-solving sequences. But let's take a look at the STIR. Now, when I look at STIR, everything that I see as high signal, I try to interpret or try to understand, could it be edema? So even starting out in the hindfoot where I see the talus and the navicular, when I look at the lateral aspect of the navicular, I see some kind of edema, subtle changes between the navicular and the cuboid and the calcaneus at that location. And then I see that the third metatarsal base has this edema that extends to the diaphysis, and that there is even some overlap of the third to the fourth to the fifth metatarsals. And we'll come back to that. Now, what I want to understand there is, do I have a fracture there? Is there a fracture line I can see? And what I don't see is a fracture line. I do see some degree of a bone erosion, perhaps where there's a loss of cortex in this location. So that's what I see in that location. And when I look at that on a short axis image again, when I look at the base of the third metatarsal, so here's my navicular, my cuboid, and my three cuneiforms, and coming into the third, what I'm seeing in that location is I see degenerative changes between the base of the second and third. And then on this side here, where we're looking at, let's see if we can see it on the Dixon, we can see that possible erosion or synovitis. So in the back of my mind, there are a couple of reasons why I think it could be there. I think that when I look at the Roman arch of the forefoot, that I can be having some stress-related edema just on the way that my Roman arch is actually forming, that it can have stress reactions in that location, particularly when I have to come down on my side of my foot and then off to the toe off. The biomechanical gliding that might be set up, because this is a very steep angle, may cause the patient to have like a boom, boom, and a very rough biomechanic hitting these metatarsal perches and then toeing off. Now, we know that they're having some dysfunction because we can see that there is a certain amount of sesamoiditis. But let me get back to this area over here. So what I'm seeing is I see edema. And on the T1, I saw that there even was some erosion. So at the most, I'm going to call this as a stress response. I'm going to hold off on the erosion first right now, because I like to be sure when I'm calling erosions that there's actually erosion and not just some reason to have nonspecific synovitis. So to see one erosion is not enough for me to call this an erosive pattern of gout. Let's keep going. So I see, and I'm also seeing some degree of changes at this central area of the anterior subtalar joint where they all line up, which may mean that the vector of my foot goes through this region as part of their weight bearing. So I'm considering this as biomechanical right now. So when I do think about erosions in the foot, obviously I'm going to go to the hallux MTP and try to convince myself, because I don't know that many people who have gout that doesn't affect the hallux MTP, but would only affect here. There are some drugs that can do things like that, like cyclosporins and things I've seen do more or less erosive changes at the midfoot, and maybe they're sparing elsewhere, but that's not a hard and fast rule. So right now I'm thinking that this is all based on stress-related change from overlap, and in fact that the vector of my foot might be a pes cavus, where the vector of my talus as I drive it down is actually overloading this particular region. And let's take a look at the muscles here, because we can see that there is some degree of edema in my muscles in this particular location, some edema, some atrophy. Let's go back over here. So I think there's some interosseous muscle atrophy in this location, and that's adding to edema. This is more of a neuropathy. When I look at the forefoot parabola, notice that there's a flattening or an inversion. So if I use my schema thinking that there is some compression of this third metatarsal between my Roman arch, and that's adding to my biomechanical disadvantage, then I would expect there to be some kind of plantar capsulitis where my third is really landing. Now, it's not a dropped third metatarsal head, but it's subtly flattened, and there is some mild reversal of this parabola. So these guys are really under a lot of stress. Let's take a look at how much stress. Let's take a look at the Dixons and see. So what I'm seeing is that all the plantar capsules are kind of indistinct, stretched, and thickened. And what When I'm looking for tears, this is not sharp. Let me see where else I got. So a lot of blurry imaging based on this areas here, but I'm looking for a plantar plate tear. And I'm thinking about, let's see, going back to this guy here. There's a lot of magic angle that I feel that go on with this. And so I'd really like to have a straight axial PD fat sat. This is a Dixon non-fat suppressed. Let's see if I have to window it. Okay, let me see my sagittals. Yeah. So there's a lot of blurriness when you're using these images. So I don't feel confident in what I want to say about them, but let me just take a look here. This is your 3-dimensional and lots of images, but let's see what we can learn about them. I'm trying to get over to, so here's our 5th, 4th. I'm looking for plantar capsular detachments, just grossly spinning through 3rd. This is thick. Maybe there's some sprain. And here's my 2nd. And I think that what I see here is a low-grade partial tear of the plantar plate closer to the hallux side here. That's what this is right there. And I don't think it's easy for most people in the world to look at it that way. So I'm going to go over here and see what else I can use. I think this is going to be my best hope for it. So what I'm looking at here in terms of my plantar plate is poor definition of the plantar plate in this location, a low-grade partial tear. I'm looking for my U-shaped structures. And what I'm seeing is that on the fibular side, here's my phalangeal attachment. And as it gets toward the metatarsal attachment, poorly defined. So some plantar capsulitis, no detachment. I can see the same thing on the tibial side of this plantar plate, kind of thick, not focally torn or detached. Again, I think it's part of the imaging that's not crisp, and I would like to see this in a T2 fat set or an axial PD higher res. What I do see is a very large third interspace neuroma or pseudoneuroma, because I'm going to be looking for the plantar plate tear. Now, for this plantar plate, this is quite irregular. Even the collateral ligament on this side is sprained. And I'm going to look at that. Now I'm going to go back to my coronal stir and try to understand, because probably this is the best way for me to read it based on the imaging. But what I'm seeing is a plantar capsulitis here and here. You can see that right deep to the plantar capsules. This is going to underestimate a neuroma. You're going to see it very well on a T1 image where you can see it right here. And I would be calling this a pseudoneuroma because it's hugging my 3rd metatarsal plantar plate here. That is hugging that side. And that's something that's been known to occur in patients who have plantar plate tears. So when I look towards the plantar plate on this side, I can see there's some changes there. My advice is to decrease the number of sequences, absolutely, and to be able to, if I'm going to have metal, I don't prefer to use a short axis stir for plantar plate imaging. I think it can be underestimating the disease and really make it too dark for you to see. But I would be using an axial T2 fat set. I believe the metal is far enough away from the issue that I would be able to get a good look at those. But altogether, what I'm seeing here is on the order of low-grade plantar plate, plantar capsulitis, 3rd interspace neuroma. Now let's try to look at the plantar fascia. I can see that you have fibromatosis just because of the thickness of the plantar fascia here, and that's a fibroma that's inflamed and has length to it. Why I think this is occurring is because this part of the person's foot is actually hitting the ground more than you realize, as this may be a trampoline and the inability of the forefoot to sort of elevate this person's foot. So there's greater degrees of stress on this plantar fascia. And what else can I show that with? This can show us this particular area, but I think that you're having a plantar fibroma. There may be a partial tear. And I would like to see this in a sagittal stir, if anything, so I could really be sure of what I'm seeing. But to my eye, there's quite a lot of edema. It's wavy and lax, and I am pretty sure there's going to be a high-grade partial tear in that location. I want to take back high-grade partial tear. I see a lot of inflammation around it, but I don't, and I do see this elevated signal. So there is a partial tear in terms of, let's see what I can see on the stir for this location. And what I'm seeing is I can see the cords of the plantar fascia, and I can see how they're supporting my plantar capsules there, my flexor tendons. But in this location, I'm just seeing fibromatosis and not much more that I can discern there based on this imaging. So if I'm doing imaging of the forefoot and I had metal in the hindfoot, I wouldn't want to do all of these proton densities because it's just escalating the issue and making more artifact. But I would definitely want to get a sagittal stir, a short axis T2 fat set. Or an axial PD fat set. I could try that in the forefoot using a field of view. By the way, this field of view is way too large for just the forefoot. For a dedicated forefoot study, if you want to take all comers, you can scan through the level of the midfoot, include the Lisfranc ligament, and go out to the forefoot. If I'm just dealing with the forefoot itself, like in an osteomyelitis case of the toe, then I want to actually just go mid metatarsals out, because the field of view can be really helpful when you cut it down to about 10 centimeters. Keeping it at this long level is really going to hurt your imaging. So I had spoken before about there being a lot of action in this location. And based on this, I think you have an ankle arthroplasty here. Based on the location, I would want to see some weight-bearing x-rays as to what is the vector of this person's foot. But it may be that there is a lot of stress towards the third metatarsal based on what I'm seeing as a hindfoot valgus in this person, because I can see the calcaneus very well, and the talus is not actually going medial. So the fact that I have this relative hindfoot valgus and I have this arthroplasty that seems to be pointing in this direction is making me think pes cavus, which that would give a lot of stress along the third metatarsal, and that would make sense for what I'm seeing here altogether. So I hope that that's been helpful. We can talk about it Friday and clarify anything that I didn't make crystal clear. Thank you again.